this International Myeloma Workshop is packed with lots of really interesting presentations and sessions. And the biggest problem I have is just getting to all of them and keeping up with everything that's going to be presented. I'm giving one of the great debates with Luciano Costa, and we are talking about can we give our patients treatment-free intervals? Dr. Costa is the yes, and I'm on the no. And from my perspective, I don't think we can give our patients treatment-free intervals until we can identify which patients who can stop therapy without negative impact. And so I come from the perspective that we need to continue therapy until progression if it's well tolerated, and that's a very important caveat. And this is both transplant eligible and transplant ineligible patients. We've seen this already with maintenance therapy, that patients who receive maintenance therapy for a fixed duration of time have earlier progressions after stem cell transplant. And now we're seeing with the transplant ineligible population that the continuation of therapy after some form of induction treatment is associated with superior progression-free survival. The major issue that we have is, will this translate into an overall survival? And I'd like to refer to an editorial from Drs. D'Souza and Loniel from JCO, which just came out this year discussing the Eloquent study. And what they showed is that, this is by Paul Richardson, he showed that there was no overall survival benefit, but there are a large number of patients who are still alive 10 years into the study. And so the editorial was what the Princess Bride teaches us about outcomes in multiple myeloma. And to paraphrase, 20 years ago it was inconceivable that the median overall survival for a myeloma patient would be in excess of 10 years. Yet here we are using modern myeloma therapy. And so this points out the great thing for our patients, that continued therapy is now improving patient overall survival as well as progression-free survival. And we have so many options now available for our patients to treat at progression that we now have patients who are living very long periods of time, which is great for our patients. It's hard if you're trying to have an early endpoint, and thus it does bring up my other concern and point that I'll make in the debate, that we need to develop early surrogates for progression-free and overall survival. Now, one other important point is that there were two cautionary tales, the checkpoint inhibition in myeloma combined with IMiDs, where the combination of an IMiD and a checkpoint inhibitor led to a decreased overall survival despite some progression-free survival benefit early on in this patient population of relapsed refractory myeloma, as well as upfront myeloma. And then also the cautionary tale of the use of venetoclax combined with bortezomib dex, in that the patients who received venetoclax, who were not 11-14 translocation patients, had an inferior overall survival. And there's a variety of reasons as to why both of these occurred. But the thing that's very important, we need to realize that we need to monitor for overall survival, but we need to now figure out a way to be able to develop an earlier endpoint to help us guide future studies and trial design.